colleagues from our 4 other hospital foundations. Although each of the Samaritan Foundation hospitals each have their own foundation, we work together to fulfill our shared Samaritan Health Services mission in building healthier communities together. Our virtual talk today is presented by GBC Construction, a Samaritan Pride Partner business supporter. Our Pride partners support our vision and values in serving our community with passion, respect, integrity, dedication, and excellence. Thank you, GBC Construction, as well as the many foundation, trustees, and donors who are joining us today. So before we get started, we would like to ask you to please turn off your cameras and mute your device mics at this time. And after the presentation, we will invite you back to rejoin for our Q&A. It is now my pleasure to introduce to you Dr. Paulina Kaiser, the Director for Health Outcomes Research and Evaluation at Samaritan. Paulina joined Samaritan in 2016, and after completing a postdoc in epidemiology with Oregon State University's College of Public Health. At Samaritan, she supports the development and execution of investigator-initiated research projects, from retrospective data analysis to randomized clinical trials. Thank you, Paulina, and welcome. I think your mic is muted, Paulina.
Man, I was so close to getting it right. Okay, is that better?
Yes.
Okay, thank you for letting me know. So thanks, Gerald. I will repeat myself. I'm here to provide a brief introduction to research at Samaritan, and then I will hand it over to Dr. Delmonaco for today's main presentation. So I'm pleased to represent Samaritan Health Outcomes Research and Evaluation, which is actually a brand new unit that brings together some existing personnel at Samaritan to better support research-related activities across the system. So we've existed for about a week and a half now, so it's very new, but we're definitely excited about it. So this is what our org chart looks like. I'm the director. As Daryl mentioned, I'm an epidemiologist by training. The rest of our team includes expertise in clinical research, biostats, and IRB and regulatory compliance. So everyone here has been working at Samaritan in these roles for a while now, but we used to be split across different departments. So we're really excited about the opportunity to be combined and better aligned to support kind of a spectrum of research activity. So currently Samaritan participates in 3 different kind of buckets of research. So first being the sponsored clinical trials. So our clinical research team typically manages about 50 patients at any given time in active studies or in follow-up for pharmaceutical and device trials, largely in oncology and cardiology, as well as rheumatology and pharmacy. Second, we support investigator-initiated projects from Samaritan providers. So this would include the GOTCHA study that we will hear about shortly. The bulk of this bucket is actually projects with residents to do scholarly activity as part of their kind of graduation requirements. But we also support requests for program evaluations and impact assessments from various internal departments. And then finally, we have a small but growing number of collaborative projects with faculty at OSU. So for example, we have some cool metabolic research happening with public health faculty at the Samaritan Athletic Medicine building, which is actually on OSU's campus right next to Research Stadium. And we're currently working with a professor in the College of Engineering on a grant that was recently funded by the National Science Foundation to do some large-scale data analysis using machine learning techniques to understand the impact of COVID-era changes on health outcomes, both for COVID patients and for non-COVID patients. So there's a lot of interest from both Samaritan and OSU to increase the research collaborations that are happening, and I think there's a lot of potential, and that's definitely an exciting area for growth. So looking to the future, we're trying to kind of hone in on our vision and goals for research at Samaritan. Some of the key themes that we've identified so far that really build on the work that we are currently doing is to be able to expand opportunities for patients to access novel therapies, support the development of research skills, in Samaritan staff and trainees, and really helping to support a culture of evidence and help Samaritan grow as a learning health system. And then finally, really collaborate with external partners and leverage some of the wide array of expertise that we have in our region to be able to do some nationally competitive research to advance knowledge. At a more granular level, there are a lot of different elements that go into supporting these types of research activities. So as an example for the Gotcha study, so we were involved in helping to design the study, so thinking about details like inclusion criteria and choosing comparison group, as well as drafting the study protocol, submitting all necessary documents for IRB review, and then when approved, actually, being able to identify eligible patients, informing them about the study, collecting informed consent, and then reviewing chart notes and lab results to abstract the data necessary, doing the actual data analysis, and then helping to prepare summaries and dissemination materials. So we really have the expertise to provide, again, be able to support kind of all elements of the research process. So with that little peek into the work that kind of happens behind the scenes, I'll turn it over to Dr. Delmonaco to talk about maybe the more exciting parts of the research. So I am pleased to introduce Brian Delmonaco, who is the Medical Director for Pulmonary and Critical Care at Good Samaritan Regional Medical Center. And I think if I exit.
Thank you, Paulina. That was a wonderful introduction and review of our research team. Fantastic. I am going to start my presentation shortly as soon as I can take control of the slides. Thank you, Whitney. That was perfect. I hope everyone can hear me okay. I'm Brian Delmonaco, as Paulina mentioned, and it's a real pleasure to talk to you today about some research that's homegrown, and it's really exciting. I wish we could meet in person. One, it's hard to show enthusiasm through the computer, and two, it would just be wonderful to meet everyone here. I hope at the end of my talk, some of my enthusiasm wears off on everybody, and we get to meet in the near future to talk about the next steps. So we have I hope everyone's not burnt out from talking about COVID-19, and this is really in my lane in critical care and pulmonary medicine. COVID-19 is essentially a pulmonary disease that has hurt so many people. And for this talk, which I'm going to try and speed it up because I know we have a short amount of time. Maybe I can finish in the next 30 minutes or so. I want to go over our Samaritan experience with COVID-19, and then bear with me, this part about disease characteristics, many of you are aware of this, but it'll help build the inspiration for our Gotcha trial. I'll also review our hospitalized patient data, and then the actual Gotcha trial, and then some parting words on research and collaboration. And I should tell everyone that what I'm about to show, particularly the Gotcha results, you are the first audience to see this. And it's really exciting to be able to share for the first time our research results. Just a couple of days ago, I copied this slide from the New York Times, and it's just to remind us that COVID-19 so far has affected over 20 million people with almost 750,000 deaths around the world. It's quite the pandemic. The disease itself, as I mentioned earlier, is primarily a pulmonary disease. And this is a picture of a diseased lung from COVID-19 in the first ever double lung transplant patient. What's very remarkable about COVID-19 and its pathology are the three stages that we see. And early on, patients are usually at home in stage 1, and then they require oxygen and can't breathe very well in stage 2. And then the inflammatory response really takes off in stage 3. And stage 3 is typical of when we see patients in the intensive care unit. This is a cartoon representation of the coronavirus with its spike proteins. Everyone is so familiar with this. And the other cartoon on your right is normal alveolus in the lower respiratory tract, and then diseased alveolus. And what happens with COVID-19, this cartoon represents it really well, is you see those yellow kind of hairy cells that are called type 2 alveolar cells. They, we think, allow the virus to enter the alveoli and then cause all kinds of problems, including filling up with fluid and inflammatory cells, and eventually fibrotic cells and scar tissue. And I want you to keep that alveolar type 2 cell in mind as we go through the pathophysiology. So early on in February, there were some brave coroners and medical examiners and pathologists who did autopsies on COVID-19 patients. It was very remarkable. And since then, we've had about 99 patients who've undergone autopsy. The lungs we see are filled with scar tissue and inflammatory cells. The oxyhemoglobin desaturation curve is very much at play with COVID-19. I like this picture because of not only El Capitan in Yosemite, but the fact that that curve drops off like a cliff. So as our oxygen saturation decreases, our partial pressure of oxygen in the arteries decreases. This is a very remarkable finding of COVID-19, that some patients actually have very, very low oxygen saturations, but they don't tend to have much in the way of difficulty breathing. And it makes us wonder why that might be. So the equipment that we have at our disposal, we have ventilators and we have PPE to keep staff and other patients safe. And to be honest, we don't have much else for COVID-19. So, so far, as of this week, in all 5 Samaritan hospitals, we've had 700 cases of COVID, and 54 of those, only 8%, have needed hospitalization. Our death rate, our mortality rate is about 3% of the 700. And then the sickest patients who end up in the ICU have a long ICU, relatively speaking, have a long ICU course, about 7.9 days on average. And then those who need the ventilator are 13 of the 54 hospitalized patients. And on the next slide, those patients who are intubated and on mechanical ventilation, 13 of 700 is 2%, but 13 of 54 is 24%. And that 24% is a remarkably high rate for patients who are admitted to the hospital with COVID-19 who end up on a ventilator. I'm proud of this average number of days on a ventilator at Samaritan is 5.5 days. I'll show you some data from the Global Virus Registry that shows that we're doing really well actually in beating the global average for days on a ventilator. And so this is the virus or viral infection and respiratory illness universal study. This is a registry. Samaritan is, our data is in this registry. We're up to almost about 17,000 hospitalized COVID patients and almost 5,000 ICU patients. You can see the median age of COVID-19 hospitalized patients in the registry is 60. About 29% are on ventilators. Almost all need some sort of oxygen. And the median days duration on mechanical ventilation is 9 days. And this is another part of the virus registry that is interesting and helpful when we see kind of how we're doing. So this is I don't know if you can see my mouse, but about 53% of hospitalized COVID patients are discharged home without assistance. And that's a remarkably low number. 19% have died in the hospital, and then about 2% have been discharged to hospice. So the mortality on what we think the mortality of COVID-19 in the registry is about 21%. The National Institutes of Health have been at the forefront of helping us care for COVID-19 patients, and their treatment guidelines I can summarize it here very briefly. So in other words, we don't have a remarkable tool or cure for COVID-19. We have dexamethasone, which we've used for years for ARDS, and we have remdesivir. And remdesivir, as we get more and more data, it appears that it's really helpful to decrease the number of days of illness, and it really is for a select group of patients who aren't the sickest patients, who are not on a ventilator. So many people are looking for ways to help and adjuncts to dexamethasone and remdesivir. As a matter of fact, if you go to clinicaltrials.gov, there's about 3,000 COVID-19 studies that are ongoing. I'm proud of the fact that Pioglitazone, the drug of our GotCha trial, is the only drug in the clinicaltrials.gov study that's being studied in Oregon. And then just this week, a second study popped up on clinicaltrials.gov to look at over-the-counter medications and their effects on COVID-19 illness. And that brings me to the GotCha trial. So GotCha, which stands for GlitazOne Treatment for Coronavirus Hypoxia. I just wanted to give you a kind of the inspiration for this study. Early on, it was around April, early on in the pandemic, April of this year, we noted that in our intensive care unit, 100% of our patients had an elevated A1C, or glycosylated hemoglobin. This is a marker, as you know, of diabetes or prediabetes. We already knew that diabetes was a risk factor for severity of COVID-19 illness. But what was really remarkable is that patients that didn't even know they had diabetes were getting very, very sick and ending up in our intensive care unit. And this X-ray progression is our very first patient that we treated with pioglitazone. He had a remarkable improvement in his aeration of his lungs from left to right. And then his lab markers had a remarkable improvement when we started him on pioglitazone. You can see this C-reactive protein went from very, very high, greater than 27, to 8.36, and it eventually went on to normal. This brings me to pioglitazone. I know Bruce Springsteen may be a polarizing rock star, but I really like his lyric, well, now everything dies, baby, that's a fact, but maybe everything that dies someday comes back. It reminds me of pioglitazone. This is a drug that has been around for several decades to treat diabetic patients and has never been, as far as we know, tested in COVID-19 patients. What's interesting about pioglitazone, it does have a history of being studied for influenza A. And so after I noticed that all of our patients in the ICU had an elevated A1C level, I asked our Good Sam's Chief of Pharmacy, Dr. Jared Brubaker, if he was aware of any diabetic agents that had ever been studied to help ARDS patients or viral illness patients. And he immediately recalled that pioglitazone had some remarkable studies that showed mortality benefit in influenza A patients. So this is our gotcha study protocol taken directly from our IRB submission. One of the concerns with pioglitazone, it's what we call an ACE2 upregulator. And pay attention to ACE2 or angiotensin converting enzyme 2. Early on in the pandemic, the SARS-CoV-2 virus was hypothesized to gain entry into human cells through the ACE2 receptor. ACE2 receptors are found in multiple organs, including nasal epithelium and the lower respiratory tract, as well as the pancreas, liver, kidney, and heart, and blood vessels. So pioglitazone, we know upregulates ACE2 receptors. And so one concern would be, well, if the SARS-CoV virus gains entry into human cells through the ACE2 receptor, and pioglitazone upregulates ACE2, then maybe pioglitazone will make patients worse who have COVID-19. And this is a very complex set of enzymatic reactions that takes place, but it's actually it's interesting, and I think what we're hopeful to prove is that pioglitazone, through its upregulation of ACE2 receptors, actually decreases the COVID-19 illness. And I'll show you why here in a little bit. So this is, somehow it looks like my slides went backwards. Hang on. Let me catch up. So I was talking a little bit about pioglitazone and maybe some of the theoretical problems with COVID-19. But this is the proposed mechanism of action of how pioglitazone may actually help patients with COVID-19. In the orange text, you'll see the three mechanisms of action that pioglitazone affects. And those are the PPAR gamma receptors, the protein kinase pathways in macrophages, and then something called 3CL Pro.
Hey, Brian.
Hello?
I don't think we're on the right slide.
Okay, so, yeah, it looks like somehow I lost control of the slide. So let me try taking back control.
There, you got it, Brian. You're back now on proposed mechanism of action.
All right.
Oh, thank you, Barry. I'll just repeat in orange. You'll see the text for the proposed mechanism of action. PPAR gamma is an agonism of PPAR gamma is the proposed mechanism of action for pioglitazone to decrease inflammation. And then the protein kinase pathways in macrophages. We think this is how pioglitazone decreases the interaction of SARS-CoV-2 with human cells. And then 3CL Pro, this is a necessary protease for the virus to replicate. And pioglitazone actually inhibits 3CL Pro and therefore decreases viral replication. So this is a cartoon of this idea that 3CL Pro and anything that may dock or inhibit this protease would decrease or stop viral replication. And in this article from May 2020, pioglitazone was actually mentioned as a potential drug to stop viral replication. And then the cytokine kinase inhibition, the researchers from San Francisco were trying to find existing agents or prodrugs that would inhibit viral interaction with humans. And this cytokine kinase inhibition was found to be important for the SARS-CoV-2 virus to infect human cells. So on to our gotcha results. So we placed 10 patients on pioglitazone. Many of the patients were quite sick, and the results aren't completely finished because we are following the patients up to 30 days out from their hospital stay. The interesting and successful part of our gotcha study, which was really a study about the safety and tolerability of pioglitazone, was that we had very few serious adverse events, and I would say none that were directly attributable to pioglitazone. And then our second table of results is, this is the part where we have an interesting signal. We can't really say that we've proven pioglitazone helps patients, but certainly our signal from the gotcha trial is that it is beneficial. And if you look at our mortality during hospital stay, you'll see that our pioglitazone patients, the mortality is at 10%. And then for all other Samaritan COVID-19 patients, the mortality is 14%. And then from the virus registry, it's even higher at 19%. So this, in other words, patients who received pioglitazone had a mortality of about 10%. And this is a remarkable number compared to even other Samaritan hospitalized patients or worldwide in the virus registry. This is a graph of some of the lab studies that we were following with our pioglitazone patients. And there are two labs in particular that, if you look on the x-axis, day 0, did I lose you?
Yeah, we can still hear you, Brian.
Okay. And can you still see my, okay, there we go. So on day 0 of starting pioglitazone, we followed the inflammatory marker labs, CRP and LDH. And I'll just try and go back one slide if I can. So on day 0, the CRP levels, and this is a general trend. It's kind of like one of those magic eye posters you kind of got to look at and then you'll get it. But there's a trend for decrease in CRP with pioglitazone, or C-reactive protein. And then the LDH levels, and this is easier to see, I think. You can see from starting pioglitazone on day 0, a remarkable decrease in LDH. And then I just wanted to finish up with the next steps for Samaritan research. So this was gotcha was a very small trial, 10 patients. I think it was a success and showed that pioglitazone was safe and well tolerated for our hospitalized COVID-19 patients. But what we really would like to see is there an effect on outcomes, not just its safety and tolerability, but can it actually reduce 28-day mortality? And so we have a hypothesis that through those 3 mechanisms of action, pioglitazone can have a significant effect on outcomes. And we'd like to do an open label, randomized and multi-center large trial to test that hypothesis. So in finishing up, in summary, I think it's important to acknowledge that Samaritan research contributes to the advancement of our knowledge of COVID-19 treatment, not just through the gotcha trial, but through the collaboration of all 5 hospitals. Samaritan research contributes to our community and the concept of pride in Samaritan's mission statement. Also, we've had interest from multiple large medical centers to collaborate with our research team to study pioglitazone in the Gotcha 2.0 hypothesis. And I'll finish there for questions and answers.
All right, thank you, Dr. Delmonaco, for sharing this very interesting, exciting research. At this time, we welcome our guests to turn your cameras and device mics back on. If you're using Teams meeting, you can chat a question by clicking on the show conversation icon, or you can raise your hand by using the hand icon. If you're on the phone, you're welcome to interject a question at a moment of pause. We'll just do our best we can to field the questions in order that they come. And to begin, I would just like to ask a question, since I'm here help facilitating and I can do that, is what does a large trial entail? What does that mean as far as a time frame, the length of it, resources required to do such a large scale trial?
Daryl, that's a great question, and I'll start an answer and then lean on some of the other research team, some of the experts that are on the call. So you know there have been large trials published for COVID-19, and those trials were rolled out very, very quickly. The recovery trial, the ACT-2 trial, the SIMPLE trial, and those covered really remdesivir and dexamethasone. And they looked at those drugs kind of in different ways. And, you know, the trials are still, the data is still being collected. So it's really preliminary results that were resulted in, and in some cases, not even peer reviewed. And so what it entails for a large trial, well, number one, it depends on the power of the trial. And so how we define what's a powerful trial, that drives how many patients need enrolled. And also, you know, the effect that we're looking at is really twofold. Number one, it's mortality, and the other is the amount of oxygen requirements of the patients. That's some background. I don't think it answers your question exactly and specifically. I could give you a guess, which is hundreds of patients. The recovery trial, the dexamethasone trial from out of the UK, I believe, you know, was hundreds of patients. The remdesivir trial was thousands of patients. So we do have some precedent for how many COVID-19 patients we really need to look at, and it's probably somewhere in that range. Paulina, I'm gonna pause there and see if you have anything else to add.
Yeah, it's a great question, and we don't have all of the answers. I think as far as Samaritan goes, the next step is to write out the protocol and launch a randomized trial here with the patients that we have access to. Fortunately, it's actually not that many patients that we have with COVID in our region, which for the study is kind of a bad thing, but don't get me wrong, as a global phenomenon, it's definitely a good thing. But that being said, I think that speaks to the importance of being able to work with other partners and finding other healthcare systems that can help get us more patient numbers so that we have better statistical power to precisely estimate any differences between the patients who get pioglitazone and patients who don't. So again, working through those kind of collaborative agreements always takes time. So I think it's hard to estimate as what the timeline would look like for that collaborative piece of any future research. But definitely at Samaritan, we can definitely move forward with doing a randomized trial with the patients that we have here.
Okay, Dr. Delmonaco. Steve Erlings asks if you're still looking for participants for the study and how they might apply.
Well, for Gotcha 1, we've finished enrollment. And so we met our goal of 10 enrolled patients. And our other goal was to find a matched cohort, so patients who didn't receive pioglitazone. And we weren't able to meet all the criteria to find 10 matched patients as well as we would like to. That's okay. Actually, I can't remember if it was the ACT-2 or the SIMPLE trial. It may have been one of the convalescent plasma trials that are ongoing. They're unable to exactly match a cohort. It's just very difficult, and some of the demographics have changed. But for Gotcha 2.0, it would be wonderful, except for what we're thinking is it's going to be limited to hospitalized patients. The doctor may be asking about pioglitazone in the outpatient sector, and that's a good question. I think this lends itself to 50 to 100 different research studies of not just pioglitazone, but in hospitalized patients, but diabetes and outpatient and novel treatments for COVID-19. I get very enthusiastic and start getting excited, so I'll just pause there and see if you have any more questions.
Tom?
Yeah, I'm trying to write. I didn't realize the writing part. I'm just going to ask them. I have a bunch of questions, but I'm only going to ask 3. Were the patient characteristics in those you treated the same as those that were not treated? We didn't. Just a yes, no. Age, comorbidities, etc.
Well, it's no. The answer is no. But I beg to inject something here. You know, if you look at the recovery trial, which was really a successful look at dexamethasone, I think it's only about 15% of the patients were on oxygen. You know, if you're on room air and you have COVID-19, you really have mild illness. Now, we worry that you'll go on and get severe illness. Our patients in Gotcha were moderately to severely ill. And I think, although it's a small cross section, we really have a collection of patients who we didn't just just pick patients that were going to get better and go home anyway. These were patients on high flow oxygen, and 80% of them, I believe, received remdesivir, and I'm guessing 90% received dexamethasone. I don't have the data right in front of me.
Okay. A second question. You showed the slides of the trend of decline in CRP and LDH in those that you treated. Do you have that data on people who get better similar to these who did not receive pioglitazone? What happened? Did their CRP and LDH stay high, or do you even know that?
I don't have the Samaritan collective data for that. Olivia, if you or Steph, you might have that to show. I can tell you though, my suspicion is though that you're right. CRP, LDH, and D-dimer do not improve and stay low for patients who go on and are the sickest patients and who die. We can see some of that data in the 10 pioglitazone patients. The one who died, their lab values did exactly what I just described. They responded initially, but didn't have a sustained response. Yeah.
So yeah, I know that pioglitazone is associated with declines in a lot of these inflammatory markers separate from this disease, and you know that was a postulate raising property to maybe use it, but I just wondered if that was going to happen anyhow, if these people were going to get better without the drug. It might. I mean, of course, if you do a large study, you're gonna have that. The third question is that I'm going to ask is why open label? Why do you want to do an open label trial instead of double blinded and closed?
Well, that's a great question. So pioglitazone is already approved for the patients who receive pioglitazone. They already had an indication to receive it. They had an elevated hemoglobin A1C. And so The other, maybe I could explain it the other way. The other route would be to do a investigational new drug application to the FDA. And to do a blinded and placebo-controlled study. But this was a way to in a homegrown effort, study the safety and tolerability of a novel treatment without having to apply to the FDA for an investigational new drug. The next step, I think you're right. When you're doing that sort of scientifically rigorous study of potentially thousands of patients, and you're investigating a novel therapy, would require something like the FDA or the NIH or a grant, that sort of thing, that sort of impact and regulation to put through.
Thanks.
Chris, would you like to ask your question?
Sure. Thank you. Great work by you guys, by the way. This is fascinating information. I'm wondering if I'm not a doctor, so it sounds to me like there's a lot of inflammatory response related things going on. And I'm wondering if you have any hunches from what you've learned on proactive steps that could be taken.
I have a bunch of hunches, and I fear that I haven't been able to express that very well today. But I want to leap off of something you said. This notion that diabetics or pre-diabetics get sicker and die from COVID-19, and the idea of the ACE2 receptor, and what happens in diabetic patients? Well, they have extra high levels of glucose, and sort of chronically. They also have chronically high inflammatory markers and are susceptible to myocardial infarction, stroke, and hypertension. So if you already have at baseline high inflammatory markers, and then you get infected with SARS-CoV-2, which causes a very high spike in those inflammatory markers, you're probably going to be sicker. And then the other, now this is very hypothetical, but I think fascinating, is the role of the ACE2 receptor, because this is another interesting phenomenon that the world has seen. Pediatric patients, particularly if you're under 10 years of age, don't tend to get COVID-19 as often and don't get as sick. And we know from previous studies, I believe with SARS-CoV-1, when we swab pediatric patients and look for ACE2 receptors in the nasal epithelium, their levels of ACE2 are quite low. And so one theory is that if you have low ACE2 levels in your nasal epithelium, you're probably not going to get infected with SARS-CoV-2, and you may not get as sick. And then the other part of that is if you don't have baseline high inflammatory markers, then you're probably not going to get as sick. I might add that pioglitazone, we know upregulates ACE2 receptors, and the angiotensin converting enzyme 2 receptor is important in many of the organs in humans. Particularly, what we don't know is if a low or a high ACE2 receptor count in the lower respiratory tract is going to cause severe disease or not. The fact that pioglitazone, which upregulates ACE2 receptors, and would indicate that probably a high level of ACE2 receptors in the lungs is important for surviving COVID-19. And I think it's one of my hunches as to why pioglitazone might save lives.
Thank you.
I know we have some people on the phone. Is there anybody on the phone that would like to ask a question? Feel free to unmute yourself and ask. Okay, so I have another question, and maybe this is for Paulina, but I just was curious. I know you have part of your team, research team on the call or around, but how do you work together? How does that divide and conquer duties with this kind of thing? Does everybody do the same thing, or is there what's the process by which you do something like this?
Yeah, it's a great question. I think that we each kind of have our own areas of expertise, and so we do tend to each focus on our strengths. That said, it takes a lot of communication, and so that's why I'm so excited that we are now kind of brought into one unit, and I think that'll really facilitate all of the communication, keeping everybody on the same page. So as I said, I'm an epidemiologist, so my skill set is a lot in study design and thinking through how can we structure a study, how can we, first of all, choose a research question that's important and interesting and that we can actually answer. And then how do we design a study? What are kind of the choices that we need to make through the study design process to best create the data that will allow us to answer the research question? And so we work a lot with Olivia, our biostatistician, who I think is on the call too. So she helps a lot with the power calculations, trying to figure out, how many participants do we need to enroll? And then through all that process, as well as our clinical research team led by Tony and Steph, who I believe are both on the call as well. And they are kind of the stars at the boots on the ground. So they're the ones who are actually talking to patients, getting the informed consent, answering questions, coordinating with the physicians and all of the staff at, in the hospital who are also involved in the care and making sure that everybody knows what it means to have a patient on a trial, collecting the data that needs to be collected, that whole process. Olivia, Steph, Tony, you guys want to chime in on anything else?
I think you captured what we do perfectly. Thanks.
Daryl, I might add to Paulina and just say for this gotcha trial, it was really impressive. The 5 Samaritan hospitals spread out, COVID-19 being a disease where the patient's isolated and often very sick, and sometimes family separated from the patient, most often. That process of getting consent, the bravery of the patients and their families to try to contribute to our knowledge of the disease and pioglitazone's role in the disease. It was impressive, and the collaboration between all 5 hospitals, particularly the research team and the bedside staff, who had really made the consents happen, and sometimes dealing with Spanish-speaking only patients, particularly on the coast, was an impressive endeavor that was eye-opening, and I'm very proud of the efforts in the short amount of time to get this through.
Dr. Delmonaco, our guest Kate Harris has a question. Has metformin been used or considered as a treatment for pre-diabetics who are not currently on metformin, or proactively for pre-diabetics who are not currently on metformin?
Whitney, that's a great question, and I do think metformin is one of those 3,000 drugs on the clinicaltrials.gov. It's not currently in guidelines that I'm aware of. Certainly, once patients are in the hospital and in the intensive care unit, it's not an agent we continue or sustain. There is one other diabetic agent. It's in a separate class than pioglitazone. Pioglitazone is in a class of drugs with a big long name that we abbreviate as TZD, and it's the DDP4 class of drugs. I'm trying to think of an example. Barry, you might this might come off the tip of your brain faster than me, but it's not the glipazides. It's they're a newer, a very expensive oral anti-hyperglycemic agent, and which reminds me I wanted to mention this. Pioglitazone You might know this, has a brand name, Actos. It's now generic, but the grand total for a 1 month supply of Pioglitazone is less than $3. And it's generic and available on most hospital formularies. And so it's quite a remarkable difference. Remdesivir is about $3,000. And so the price difference is just incredible. And what I believe and would like to study is that this $3 drug saves more lives than remdesivir or any other therapy that's out there.
Great. It looks like we have Dr. Patel would like to ask a question or have a comment. Dr. Patel, I think you're muted still.
There you go. That's a chronic problem of mine. Not a question, just more a comment and more praise. I am the chair for the systems P&T committee. That's a pharmacy and therapeutics committee. And there's always this somewhat tension between critical care physicians and members of the P&T because of a lot of empiric things that happen. These are critically ill patients, and people just want to try something. And I remember a conversation I was rounding on someone in the intensive care unit, and Brian, who we've known each other for maybe just 6 months prior to that, sat next to me, and we kind of just sat down and said, how do you feel about, and he rolled out a bunch of things, starting this drug, and this drug. And I kind of turned to him and I said, I don't mind those drugs as long as you do it in the context of a clinical trial. That's been our default answer for any time a physician wants to just try something on a patient. And I'm always of the belief you don't experiment on patients. But you can do research on patients. I would say rarely do physicians take that charge. I want to commend Brian for going that extra step. We're an academic center, but we're not OHSU. Let's be real. We're not a university of XYZ. Our physicians are clinicians primarily. They don't get money to do research trials. They're not looking for grants to pay portions of their salary so they can continue to explore and contribute to the literature. And I was really impressed with what Dr. Delmonaco did in taking it to the next step and to where we are today. I know from experience that it's hundreds of uncompensated hours he's contributed. And I just wanted to praise him and also the research team for taking really this idea to this level, but more importantly, taking Samaritan to this next sort of research level. As far as I recall, this is the only study that I'm aware of in the past 10 years that is homegrown, uniquely done here, and done in the way that we can all be proud of.
Hear, hear.
Dr. Patel, you're making me smile, and very nice of you to say thank you. And I just want to corroborate one thing. We weren't going to try all those drugs on that patient that day in the ICU. We were having an academic discussion, and you're right. I think like all of us who have a patient who is not getting better, and there's really no answer out there, and you've tried the remdesivir and the dexamethasone, and they're not getting better, and you're just wondering, what else? We're missing something, and then you notice something that is true on all the patients, and then and then 2 and 2 come together, and then you go with your hunch. So, but thanks, Dr. Patel. Very nice of you to say.
So this is Dave Hess. I'm on the North Lincoln Health District Board. I'm also a experimental physiologist from OHSU, emeritus professor, which means I get a good firewall from the med school. As an endocrinologist, and as a researcher, I also would like to compliment you. This is just amazing. We should be publishing this, I mean, shouting it on KA2U and any other place that would be willing. This should be being tried everywhere instantaneously now. And as a 79-year-old, let me tell you, that's going to be the first thing I ask for. So I really think we should make this high-key stuff, not low-key. This is nothing to be embarrassed about. I agree with the last speaker. This is first-class stuff, and you really are to be complimented. Thank you.
Yes, sir. Thank you. You took the words out of my mouth. High key is a great way to say it. I don't think it's in my position. I'm not in a position really to make that happen. And so I appreciate being able to share this with all of you, this distinguished audience. You know, it's based in science, Dave. It really, I really think, things are changing, and we don't know everything about COVID-19. And I have questions, you know, but every time I have a question about why would pioglitazone be helpful, I can find an answer, or at least what I think is an answer, enough that we should test the hypothesis and go that next step. I agree.
I guess I would add, the evidence that you presented is very, very convincing, admittedly on an N of very, very little, but 1 out of 10, and all of that particular first slide you showed with the x-rays, my goodness, that would catch everybody's attention. I don't care what your background is. You'd look at that slide and you said, you did what? And it did that? You'd have hundreds of people signing up. And I would expect a number of institutions. So I think you ought to pursue that ASAP and as hard as you possibly can, of course, in your spare time.
Thank you for the encouraging words. And you know, to be honest, we have sent this out in sort of the concept form and have received interest from some large research medical centers on the East Coast and the West Coast. And I think, and rightly so, these larger research teams, they wanted to see this first trial, and then I think this will be convincing. I hope it is. And you know, the question about how big, what are the parameters of the next trial, and then funding. Those are the questions that typically come up from the larger medical centers. But when it comes to funding, I usually say, well, it's a drug that costs $3. You know, it's like, but there is certainly there are people that you know depend on, that get compensated for, you know, research, and this is the human part of this is much more important than, you know, the machine part.
Well, it looks like we're at 1 o'clock, and I just want to thank Dr. Delmonaco and Dr. Kaiser and everybody who joined today. It was very interesting, and we all are very inspired. So thank you so much. And I want to thank all the foundation donors and again, all the trustees across the system that joined us today. We appreciate all your support, and just keep looking forward to new emails coming out for the next talk that'll happen soon here in September. And I heard that Dr. Patel might be part of that, but I'm not sure. I think we're working on that. So we'll send out more information about that and we'll let you know. Thank you.
Bye-bye. Thank you.
Good to see you, Larry. Thank you, Paulina.